Hi everyone, my name is John Deakin. I'm a paramedic practice leader with BCEHS.
And hi everyone, I am Stephen Haigh. I am a paramedic practice educator with BCEHS.
Yeah, thanks Steve. So today we're just going to go over the checklist in the handbook for the TNK Fibrinolysis protocol. Okay Steve, so I see you've got a lot going on here. Before we go into the actual treatment with TNK, I'd like to use the checklist to walk me through some of the fundamentals of care for the STEMI patient. So Steve, maybe you can just use the checklist and show me what you've done here.
Sure, and I'm going to utilize the BC Handbook app for the checklist. So I've got my phone here, and I've got the defibrillator patches here. They're not actually applied because I don't want them to interfere with our 12 lead cables, but they're at the ready if they're required. John, I do have this patient on supplemental oxygen, as initially the patient's oxygen saturations were less than 90%. I have a 12 lead here that demonstrates an ST elevation MI, and we've established one IV, not two. The checklist says two if possible, but we've established one thus far, and it is in the left AC area. We've done a baseline history and examination on this patient that supports what we're finding with our ECG. The patient has chewed 160 milligrams of ASA. We haven't given the patient nitroglycerin, but it is an option at this point with the parameters of the patient's vitals, etc. And nor have we given any fentanyl or gravel at this point. And atropine is another thing that we could consider, but the patient doesn't require it at this point. Any questions about that, John?
Yeah, so you mentioned you haven't given fentanyl or gravel. That's just because in this patient it's not indicated, but it is part of your sort of care bundle for the STEMI patient, right?
Yes.
Okay, so it would be indicated, just not in this particular patient. No, that was great, Steve. Thanks for going through the checklist. I'm kind of cheating. I'm looking at a checklist off the side here. And this is we'll need to go through this step by step as we make our call to the emergency physician. Steve, we've covered the basic bundle of care for STEMI care for this patient. And moving on in our checklist is the next box is the history box. Now, there's a few items to cover here. Steve, I wonder if you could just talk us through how you're going to elicit this information from your patient.
Sure, John. This is all going to be part of our history, and I'm going to cover things here that aren't necessarily going to be conveyed to the physician when you have that phone call with him. This patient is having crushing retrosternal chest pain that is radiating into his left arm. It's not worse with any activity or exertion. It's not worse while he's laying supine, or it doesn't get better when he's sitting forward. It's not sharp-like, and it doesn't get worse with inspiration. It doesn't feel like a sharp stabbing or tearing pain. I do want to look for focal neurological symptoms, and some of those would be limb weakness, visual change, or speech difficulties. There was no loss of consciousness with the presentation, and this patient doesn't have any associated symptoms. This patient does have a couple of comorbidities, and that is hypertension and hyperlipidemia.
Thanks, Steve. So that wasn't, to be clear, that wasn't the report. That's Steve's assessment. He would have gone through each and every bullet point to rule in or rule out that criteria. And then in the report to the physician, Steve would include the items that he's checked off on that list that apply to this patient. Now that we've gone through the checklist of the history, the next item on the checklist is the physical examination. So Steve, again, a fairly comprehensive list of physical examination. I'd like you to walk us through how you're going to elicit this information and how you're going to assess this with your patient.
Yeah, thanks, John. So we're going to start off with the pupils. Are they equal in size, round, and reactive to light? We do want to do a full set of vital signs, and we are looking at the blood pressure in both arms. Our concern is if there's a blood pressure in one arm or the other that is greater than 20 millimeters of mercury, and we want to make sure that the pulses are present and equal in both the left and right arms. We want to make sure that the pulses are present and equal in both the carotid arteries. We're going to listen to the chest to make sure that we have equal air entry in both lung bases. And we're actually looking for crepitus in the lung fields. We're also going to auscultate the heart, and we're looking for possible murmurs there. And we're going to see if the patient can move all 4 limbs against resistance.
That systolic blood pressure difference of greater than 20 in each arm, that's to rule out a possible dissection.
Yes, that's correct.
Okay, as well as the pulse checks in the peripheral limbs. Thanks, Steve. So we would go through this and again, mark off the criteria that applied to this patient, and that's what you would provide in your report to the physician. The next section on the checklist covers the indications for PCI. Now, although we won't be administering TNK if we are within 90 minutes of a PCI lab, we still need to cover this checklist with a physician. This covers contraindications to tenecteplase, cardiogenic shock, severe acute heart failure, recurrent VF or VT, first medical contact to balloon time in under 90 minutes, or if the diagnosis of STEMI is in doubt. Now we're on to the indications for TNK, tenecteplase, in the checklist. Steve, this looks like a relatively short list. I see 3 bullet points on the checklist.
You're right, John. I'm just going to go through the 3 of them. So the first indication is that the time of onset of chest pain is less than 12 hours, and the chest pain is consistent with that of myocardial ischemia, and the ECG changes are consistent with ST elevation MI.
Thanks, Steve. And those ECG changes, the requirements or the findings on your ECG that are required to meet that STEMI criteria are all listed there in the checklist. Next on the checklist are absolute contraindications to TNK. This is a fairly comprehensive list, Steve. It looks like it's mostly just history taking to me, so can you walk us through how you're going to elicit that information?
Sure, John. So these are the absolute contraindications. Any prior bleeding in the brain, structural anomaly of arteries or veins in the brain, known tumor in the brain, ischemic stroke in the last 3 months, significant closed head or facial trauma in the last 3 months, brain or spinal surgery in the last 2 months, active bleeding or bleeding suspected, severe uncontrolled hypertension, which is unresponsive to emergency therapy, and suspected aortic dissection.
Thanks, Steve. So again, you're going to go through this whole list with the patient, rule these in or out because it's just a yes or no criteria. And then whichever of those checklists you answered yes to, those are the items you'll discuss with the physician on your phone call for TNK. Well, we've gone through the absolute contraindications. Steve, next on the list are relative contraindications. Also a fairly comprehensive list, but also a yes or no criteria. So Steve, maybe you can just walk us through what you're going to elicit and how you're going to do this with your patient.
Sure, John. So these are the relative contraindications. They are known intracranial pathology not covered in absolute contraindications, dementia, prior stroke greater than 3 months ago, major surgery in the last 3 weeks, internal bleeding in the last 4 weeks, BP greater than 180 systolic or 110 diastolic on the presentation, history of chronic, severely, poorly controlled hypertension, traumatic or prolonged CPR, which we're saying is greater than 10 minutes, pregnancy, active stomach ulcers, patients on blood thinners such as warfarin or direct oral anticoagulants, and non-compressible vascular punctures.
Thanks, Steve. And again, you'll need to go through each and every bullet point with the patient, rule these in or out, and then the ones that you check the yes box for are the ones that you'll discuss with the emergency physician in your phone call.
Okay, John, I'm going to read the TNK Informed Consent script, and I'm going to read it verbatim. You are having a heart attack and would benefit from potentially life-saving clot-busting medications. When given early, these drugs can prevent the heart attack from progressing and causing further heart muscle damage. They can even prevent death from a heart attack and related complications. We are able to deliver these therapies to you immediately as part of a quality improvement project. You have the option of declining these medications and waiting to be assessed when you go to the hospital. The sooner you get these medications, the sooner blood supply may be restored to your heart muscle. The risks associated with the use of these medications include, but are not limited to, bleeding, strokes, and heart rhythm problems. The risk of bleeding in the brain is less than 1%. If treatment is given greater than 12 hours after onset of symptoms, treatment may cause more harm than benefit. Do you give consent to receive this treatment?
Next, Steve, is just a very short checklist to make sure that we've done everything up to this point, and this patient meets the criteria for TNK. So can we go through that just quickly? First on the list is there are no indications for primary PCI.
That's correct.
Second point is the case has been discussed and the ECG has been reviewed by the physician.
Yes.
Next, there are no absolute contraindications.
There's none.
And are there any relative contraindications?
There's actually not with this patient.
Great. And the last one is, has the patient consented to this treatment?
They have consented to the treatment, John.
Great. Well, now we've gone through our checklist. We've identified this is a STEMI patient. We've transmitted that ECG to the EPOS physician. We've gone through all our indications, contraindications, absolute and relative, as well as received informed consent from the patient. Now we're ready to set up our medications for administration. So I just want to quickly go through the medications and the dosing as it's laid out in the handbook. In your kit, you will find enoxaparin IV, as well as enoxaparin for a subcutaneous dose. You'll also find clopidogrel and, of course, the TNK. The first medication we're giving is enoxaparin. It's in a preloaded syringe, and it's an IV dose of 30 milligrams. Now, these doses are separated to the patients that are in age less than 75 or an age greater than 75. And they're different doses, and this is very important to identify. So for patients less than 75 years of age, the enoxaparin IV dose is 30 milligrams. If the patient is greater than 75 years of age, they don't receive any IV enoxaparin. The next medication you'll be given is the TNK. The TNK is in a bottle in the kit with a syringe as well as saline flush. And the TNK is also weight-based. There is a chart in your handbook which breaks down the weight-based dosing. It's basically 0.5 milligrams per kilogram. So if you have a 60 kilogram patient, your dose would be 30 milligrams. But again, this is all laid out, and you should be checking, cross-referencing, and confirming with your partner following the 5 hours of medication administration that you've drawn up the right drug, you have the right patient, the right dose, the right route, all just good, safe practices around medication administration. Good, so we've done IV enoxaparin, 30 milligrams, if they're under 75. We've administered the TNK, which is based on the patient's weight, and that dose is halved if they're greater than 75 years of age. The next medication is going to be subcutaneous enoxaparin. So the subcutaneous enoxaparin is 1 milligram per kilogram, which we'll be administering, and that dose does have a maximum of 100 milligrams. Okay, so 1 milligram per kilogram of subcutaneous enoxaparin with the maximum. If that patient is greater than 75 years of age, that dose is reduced to 0.75 milligrams per kilogram. The last medication we'll be given is a PO medication, and that's why we have a water bottle in the kit, and that is clopidogrel. The clopidogrel for the patient who is under 75 years of age will be 300 milligrams, and if they're greater than 75 years of age, that dose is reduced to 75 milligrams. All right, so again, broken down to less than 75, greater than 75. So quick summary then, we have IV enoxaparin, and that's 30 milligrams. And then we have the TNK, which is weight-based, and that's also given intravenously. And then we have a subcutaneous dose of enoxaparin. And then we have a dose of clopidogrel, which is also broken down, again, less than 75 or greater than 75. So very important that make sure, again, use your checklist, cross-reference with your partner, recognize that there are 2 doses for less than 75 and greater than 75, and practice safe medication administration. Steve, we've covered just about everything in this checklist. The last thing to cover is the post-TNK administration. I see that the first bullet point on here is notification of ER or triage. Can you walk us through that?
Sure, John. So when we're notifying the ER, let's state when the TNK protocol was started, and let's talk about the dose that was given and the patient's weight. We want to let them know of any protocol medications that were not given and the reason. We want to give them an overview of the patient status, so GCS, appearance, vital signs, chest pain, still ongoing, etc. Well, of course, we want to give them the ETA, and if possible, let's give them the PHN, name, date of birth for pre-registration. You want to talk about the neuro?
Yeah, thanks, Steve. So there's just the last 2 bullet points. The first one is to continually do a neuro assessment. This is really important. You know, we did one at the beginning of this call to establish a baseline. We want to see if there's any deviation at all from baseline. So we want to do neuro vitals every 15 minutes, very important. And the last one is serial 12 lead. So every 15 minutes, we're running another 12 lead. And we're looking for any changes in that, specifically resolution of ST. So we're looking for 50% or greater resolution of that ST elevation, which you should see fairly soon. Certainly, hopefully you see that before you get to the hospital.
Oh, excellent, thank you.
Yeah, thanks, Steve. So thanks, Steve, for coming in and helping out with this today. Well, I hope you found this video helpful as we walk through the checklist. Thanks also to Natalie. She's behind the camera. You can't see her. And if you have any questions at all, please email me at it's John Deakin, and you can contact me at clinicalpractice@bcehs.ca. Thanks.
Thanks, everyone.